Are you guys seeing a message that this meeting's being recorded? Perfect, good, because I didn't get the message and I just pressed start recording. Okay, that's perfect, that's great. Hopefully everybody's well. I just wanted to start by saying welcome back. Great first class. Go over admin if there's any to go over. I've gotten about 5 or 6 people who've done the first assignment and they've all done an excellent job. It's always good, I think, to do the assignment prior to class. If you want to wait till after class, it ends up adding to your workload, and you're guaranteed to be prepared for class if you've done the assignment prior to class. So anyway, and then again, if you want to resubmit it because you feel like you should, you're free to do that, but it's not a big worry. Trying to think if there's anything else that I wanted to. Yeah, so again, sort of standing assignments are going to be, I'm a big fan, just so you know, I use the participant list and I use it so you guys can raise your hands and we can use it for sort of informal polling. If you all have your cameras on, I can just do people raising their hands as well. You know, like I'll say, you saw me in class last time, I'll say, you know, if you think the answer is 10%, raise your hand. If you think the answer is 12%, raise, 20%, 30%, 40%. So anyway, just a good way to keep you guys engaged. Any questions since the first class? So give me a thumbs up if you all signed up for Kaiser Health News. And what do people think? Interested? I mean, did it take more than 5 minutes to just glance at it daily?
No.
No. Okay, great. And yeah, feel free to stay unmuted unless you've got a dog barking in the background or, you know, a neighbor with rock and roll blaring. So, and that way you can just speak up, because I can call on people as well. So, you know, on the reaction side, you guys have done this forever, you've grown up with this, but reaction side, you can always just do, you know, raise your hand or thumbs up if I ask a question. So that's all good too. What I'm going to have people do is, if we can just go around the room and we can sort of just go over, you know, what are you thinking of, you know, 1 or 2 minutes each. What are you thinking of topics and what interested you and what you've seen on Kaiser Health News so far? I'd love for you guys to at least start with a topic and then narrow it down. Start with a topic, you know, even if it's a broad topic, hopefully narrow it down right off the bat. It just makes your life easier as well. And then, you know, mention what there seemed to be a consistent theme, just so you guys know, that I've heard that people really want some chatting and education on medical malpractice and burnout. So I think we should spend some time on those, and we can do it, some of it today or over the course of the next 14 weeks. So that's all fine. So yeah, why don't we just go around? My list tends to change the order of which, so sometimes it's hard for me to see who I've already called on. So rather than me calling on it, I don't know if you want to do this by alphabetical order or whatever, but just for, I'm trying to see if my class list, this is my class list that I printed off. I occasionally do kill trees rather than do it electronically. So, you know what, why don't I just do it off the class list, and that way I'll know I've called on everybody. So Monica, topics of interest from Kaiser Health News. I know it was only a day or two that you looked at, if any of them caught your interest, and then what topic you're leaning toward at this point.
I I looked at Kaiser Health News just for a while this morning.
Yeah.
I know I'm going to do something with global health, but I haven't really narrowed the topic about global health yet.
Yeah, I love global health, so that's a great topic. And the problem is, you really need to just completely hone it down. I mean, you can't do, I mean, there are literally libraries full of global health textbooks, you know, comparing different health systems. So you might want to choose a topic within public health that interests you and do comparative. And what I'd like the thesis statement to be for the papers is sort of a preventative health intervention, whether it be health policy, a program, and incentives, and then sort of do a little history on it, and then propose what is either being done and why it should work as a means of preventative health, you know, improving health through prevention, which, again, as we've discussed last week, is all of public health. And was there any topic in this morning's, I think one caught my eye. But any topic, Monica, that in the Kaiser Health news that you went, oh, that's interesting, I didn't know that, or I'd like to look some more into that, or not really, nothing caught your eye?
Uh, not really.
Okay, that's fine. You know, there's typically 20 or 30 different, I think there, a lot of stuff was on, it's, you know, abortion rights. I think there was some stuff as well by, what's this, the crazy Florida governor's name? Anyway, the lunatic in Florida who's like, you know, deemed a course on advanced African studies as being illegal. And he swore he passed laws that make it illegal to be woke. And he's been having fights with Disney. So anyway, it's just a little bit crazy because they embrace LGBTQ ideas and rights. So Ron DeSantis, anyway, so anyway, that seems to be a hot topic, but I think lots of his hot topics are just because he's going to be running for president. So it's getting in the face of public health so you can just get on the news feed. Kind of accounted for a lot of Trump's success. I mean, he just said one more outrageous thing after another, so he's constantly in the news feed. Madeline, I think, is the one who's not here. Correct. Yeah, she had another commitment. Amy.
I was kind of thinking about like the end of life and like public health solutions and then like the burnout.
Okay, great. So choose one of those two and then really narrow it down. So, and we can talk about burnout because I think burnout's fascinating, and you know what people, there's a two sort of major camps in burnout as to, you know, what's causing it. And it's a great introduction to, you know, how I approach the issue of burnout. I'll just ask you guys now, why do you think burnout is a problem in healthcare or in every potential workplace?
I think specifically in healthcare because COVID's made like a significant impact with everything. I like worked during the very beginning of COVID and I could just see the difference. I had like over half my staff quit because of COVID. So there was like a significant, I would take care of 5 patients a day. Then like before COVID, and now I'm taking care of like 15 patients a day. And it puts a lot of stress on your body. Like you're not physically able, like no one should be able to take care of 15 patients at one time. Like that's not fair. That's like, I could go on a whole tangent about it.
Yeah, no, I agree with you completely. I mean, talk about stressors. I guess the issue is, are healthcare workers, forget COVID for a second, were prior to COVID, are healthcare workers more burned out than lawyers or architects or machinists or plumbers?
I think it's unfair. Oh, sorry.
You can go. I'll go next.
Thanks, Kelsey. I think it's a little unfair to say that people in health have more or less burnout than people in other industries, only because like we know that healthcare requires so many other different fields, and like we're always leaning over to other fields to help us out. Like we lean on tech, we lean on policy, we lean on all of these different atmospheres of public health. And so, I mean, I'm not a lawyer, but I mean, I can only assume that they're dealing with just as much as we are, or there might be some type of imbalance, but who am I? I don't know.
Well, that was, I think, excellent point. Thanks for your comment. That's the reason I asked the question is this just is the issue of burnout in healthcare just because of what Jenny mentioned, an exacerbation due to COVID, or were people complaining about it prior? And I will tell you, people were complaining about it pretty heavily prior. It just got infinitely worse with COVID. You know, doctors and nurses, you know, feeling like they were understaffed and being asked to do too many things and not being in control of their work lifestyle. So yeah, I think that's important to recognize. So again, when I'm assessing a problem, I always like to assess it as to, is this unique to whatever circumstances being described in healthcare, or is this something that everybody has, and you know, every career? Because then that puts it much more in perspective. And what I'll suggest to you is that after I did just a tiny bit of research on this, it became very clear to me that prior to COVID and prior to the sort of worsening of and how difficult healthcare delivery has become, people, nurses and doctors and other providers were more satisfied with their jobs and more respected by the public. But burnout, work burnout is epidemic. That's why people change careers an average of 3 to 4 times in their career. So that's really important. Somebody else had raised their hand. I didn't want to, sorry to interrupt. Was it?
I was just gonna
Yeah.
say that it's not just segmented towards one group or one job specifically. While this is a time where more healthcare workers are experiencing burnout, it doesn't mean that others aren't. For like people who work at like desk jobs, who have been there for 10 years, who sit at the desk, do the same thing every day. It's tiring and frustrating because there is no change in what you're doing. And you have to think of like, I'm doing this all day, every day for the rest of my life. If you don't absolutely love it when you go into it, it's not going to get better. So you're going to want to do something else. Or you're just going to stay there and you're going to become depressed. You're going to have all these other issues develop because you're not able to find the joy in it anymore.
Yeah, no, I think that's spot on. And I think, I can't imagine working on a factory line, doing the same repetitive job, 100 times a day, every day, 5 or 6 days a week. So yeah, I couldn't imagine what that would be like. And how many people do you know? We can just raise your hand or give me a thumbs up, that go to work and they're like, oh, I love my job. I can't wait. I'm in a job where I'm happy. I'm getting paid. I do it without getting paid. Versus, oh my God, I'm doing this to pay the bills, and I got to figure out how I'm going to bring joy into my life. So yeah, I think it's. The majority of people I interact with sort of need to do something to keep their spirits up, especially if they have a repetitive job like Kelsey talked about. So okay, that's cool. I'm trying. Oh, hang on, let me figure out. Oh, Amy, anything on Kaiser Health News that caught your eye?
Not yet, really.
Okay, great.
I like looking.
No, that's fine. Yeah, I mean, you only had 1 day's worth. As of Tuesday, you'll have today's, tomorrow's, Fridays. It doesn't come out on the weekend, and Mondays, and then Tuesday mornings as well. So you'll have plenty of choice there. There'll be no less than 100 topics to sort of review and say, yeah, that interests me, and maybe we'll spend a little time on it just to explore it. Amisa, topics and anything from Kaiser Health News that caught your eye?
Topics of interest, I would say patient mistrust. For Kaiser, I would say I saw like they had like this whole section for recent health, and like I saw a lot of African American health, whereas I think I'd be interested in seeing more like other races and ethnicities. So maybe I don't know if that's global health or not, but just like kind of different health systems in different parts of the world and other races.
Yeah, I mean, the disadvantaged and are a wide spectrum, and the disadvantaged are a wide spectrum. As a matter of fact, even though it disproportionately affects certain races, the disadvantaged, whether you're white or just a person of color, is disadvantaged. I mean, you there's inequitable care. So I think you bring up a good point. Kelsey.
Yes. So one of like the things I'm like struggling with is like how to navigate it. I did find like this whole like separate page sort of about like abortion and like
It's a news feed. So what you'll get is, and maybe I'll try to share it with you. It's just let me see if I can screen share. I don't know if I deleted it already, just so you'll know what you're looking for.
yeah, like just like the front page.
I think I already deleted it. Hang on just 1 second. If anybody else, I don't know.
I think I found it because I found what Amisa found. So like, I'm
Okay,
more,
here, let me screen share. This is what it looks like. This is from August 9th because I failed to delete it, but let me just screen share it so everybody can see this. And I'm sure those of you who got there already know what it is, so hang on. Screen share. Okay, does that look familiar? Is that what you guys have signed up for?
yes.
Okay, great. So that's what it should be. It'll just be KHN, and I don't know if it says first edition, and then it'll be a date. And then literally you'll scroll through like, this is sewage screening. This is from August, but a lot of the stuff is redundant. And you'll go through, the screen rolls down and you'll see there's like 40 or 50 things that you look at. And again, New York Times, Washington Post, NBC News, CNN, AP, Reuters, Becker's Hospital Review. So that's what you should be looking at. And again, I literally, if you're spending more than 5 minutes on it, you're spending too much time, unless you find something of interest, in which case spend as much time as you want on it and then bring it up in class and we can discuss it. So that's great. So that's that. And then what topic were you interested in again? I apologize.
I was hoping to do something around like the area of children or sort of like more of a nursing topic. So like something to deal with like nurses or children and like any diseases or like care that's being like provided to them.
Okay, so everybody's mentioned like incredibly interesting topics and like pediatric nursing, but they're gigantic. I mean, you really need to choose, pediatric nursing, and I wouldn't even go as far as saying pediatric nursing and COVID, because that would be too expansive. Like literally choose a specific disease or a specific public health topic within children's health, and but you really need to narrow it down. Otherwise, you're going to be you're going to Google it and you're going to go, what do I do now? There's 10 pages of, there's 1,000 pages of material on this. So you really need to just choose something that interests you and is incredibly narrow. And again, the sooner you do it, the easier you make your lives, because you can just dive into it. And I'm happy to schedule at any point, at any time, hopefully in the next, 7 to 10 days, 5 minutes, either a Zoom, a phone call, whatever. If you want to meet in person, that's fine too. But just I don't have an office, so probably just easier to do a phone call or a Zoom to talk about it. Yep.
Is the Kaiser website just to like see if it like sparks any ideas for us, or
Sure,
do we
use
have
it. Yeah, if it sparks any ideas, great. That's excellent. But it would be pure serendipity if in the next 5 to 7 days, or let's say 10 days of Kaiser Health News, something, it creates a burning passion in you to write a 10 or 15 page paper on it. So I would choose something that you're already interested in and that you already have some base of knowledge in or experience in, whether it be personal or professional or prior research or prior job experience. Anything like that is great.
Okay, so we're not limited to just what comes up on there.
No.
Okay.
The only reason I mentioned Kaiser Health News is there's nothing better than learning public health through active issues, active issues that are in the news. And figuring out what to do with it, and comment on whether current interventions make sense or don't make sense. So it's literally just so that we can spend half an hour on the class to say what was in the news, what was of interest. When I was teaching class, at that time, one of the big stories was the Flint, lead contamination of water, which is a huge public health issue. So we would spend some time saying, how do you deal with this? How do you deal with failing infrastructure? How do you fund it? How do you get should there be, another great one, should there be criminal liability for those people who are aware of the contaminated source for the water? So there's just like so many things you can do to sort of explore something that you may not have explored, because kind of everything falls into public health. So yeah, just for discussion purposes. Jennifer.
For a topic, I'm like very drawn like between two, and they're very general. I want to do like something like either malpractice related or something about like the opioid crisis, like in like a specific county of New Hampshire, because I know how huge the opioid crisis is here, especially now. So I'm like, just want to figure out which one I'd be like excited to write about. But the problem is I'd be excited to write either.
Yeah, no, that's always my problem. Too many interests, too many hobbies, too many passions. I find almost all topics, whether it be philosophy, history, global health, public health, all fascinating. And there's so much to be learned. So every day, motto of life, becoming a little bit better every day. So better than yesterday, but not as good as tomorrow. So that's
Yeah.
one of my philosophies. So I agree with you. Malpractice is easy for me, and I can give you it would be easy for me to help you with really narrow your topic down, like give you a specific case to discuss, because there all of a sudden you've like made it so easy. You're going to read a decision and say, does this decision make sense, and look at some previous case law and say as a matter of public policy. So sometimes case studies are actually easy, and that's on the malpractice side. On the your other topic was opioid abuse. So a lot's been written on it. And again, like I'll just give you a perfect example because Jenny sort of brought it up. But if you were interested in opioids, but you really needed a very narrow topic, you might talk about supervised injection sites. That is a hot topic. There's some international comparisons. It's been done in Canada and a couple other places. It's highly controversial in the United States. And so supervised injection sites would be really narrowing down the topic, but you could even do it even more detailed, saying what are the difficulties when they've been done in Toronto and in Canada, and what has been easy about it, what's been difficult about it. And this is the approach we should use in the United States, or consider using in the United States. And again, narrow topic, relatively easy to research, plenty of stuff out there on it, come up with a thesis and then support it and give pros and cons. So cool.
Okay.
And did you see anything in Kaiser Health News that was of interest to you?
I saw something on last Friday's article about a California attorney general suing drug makers for overinflating insulin. I thought that was kind of interesting.
Yeah, no, it's fascinating. And again, well, let's just spend a couple minutes talking about it. So should the federal government, and typically does the federal government or state governments get involved in pricing of drugs or any product in the marketplace for the most part? Is that a common thing? Government setting prices for anything from your food to going into the hospital to what a lab test costs to what you pay for your car?
In some circumstances, yes. Like, the government dictates what reimbursement rates for Medicare and Medicaid would be, for example, and that may have a ripple effect on other health insurers.
So it's a great example, but the reality is they dictate what they pay. They don't dictate what the market pays. Now, you're right, it might have a trickle-down effect, but it's still the market that determines it. So yes, you're absolutely right. They fix prices for what they pay, but they don't fix prices for what Blue Cross Blue Shield pays, or what Aetna pays, or for the myriad of other large insurance companies. So anybody else who thinks that they're giving an example of where the government fixes prices or says you're charging too much? I can only think of one example, and that's antitrust. So if there's price fixing, that's illegal by federal statute. So antitrust behavior where there's price fixing is clearly illegal, and they get but that's rare. I can't remember the last time I've heard of a big case, especially in healthcare, on price fixing in it. So you can't go around, Blue Cross Blue Shield can't go to Aetna and 5 other insurance companies and say, let's charge $5,000 for, let's only pay $500 for MRI, so we don't have to spend too much money. That would clearly be illegal. So yeah, they generally don't do it. So it's interesting that California is going after companies for insulin pricing, and that's been in the news a ton because people have died, literally died, skipping doses, injecting themselves with half the amount they want. Any sort of ways to prevent that? anybody aware of what would be the best? So you can sue the manufacturers. I'm not sure how successful that lawsuit will be. Any other thoughts on how you can correct that problem? Overpricing of myriad drugs that are out there.
I would be curious to look at like how much it costs to like make a vial of insulin or whatever, and then see how much like companies are selling it for, just like how much their profit is basically. Like, is it driven by profit specifically, or is it more like trying to, because I don't know, insulin is a big thing that people need, and I think it's a little unfair to have how much they charge for it, especially when it's essential for living for a big population.
And it's a great point, Olivia, because there's so many drugs that are incredibly expensive that people literally will die without being able to have them available. So yeah, that's really important. And there what's the name of that scoundrel? He ended up in jail for another reason. Shkreli, something SH. He bought a company that was the sole producer of an anti-parasitic or anti-malarial. Keisha's remembering this. Keisha, can you Google it just so I can get his name right so people hear it? And just put in something SCH. Well, whatever you think, if you can Google it, just say price fixing in jail. He was out of New York. But he's literally notorious. He's the only manufacturer, and it was like a $3 drug. And he raised the price to $200. And since they were the only manufacturer, and he was just sort of shamed, but he just sort of said, hey, that's market forces, that's capitalism. And I think it's an anti-parasitic drug.
Was it Daraprim?
That could have been it. What was the guy's name? It's something Shkreli.
Turing Pharmaceuticals, but I can't find the. Scott Spencer?
No,
That's not it.
Well, anyway, you guys get the idea, and I can get his name if anybody's curious about it. But it's not the first time it's happened that sole producers of inexpensive drugs get bought out only so that they can just quadruple or increase 10 or 20-fold.
Oh, I found it.
Oh,
Martin Shkreli.
oh,
SHKRELI.
yeah. At the risk of this being recorded, what a completely immoral, unethical human being! Just shocking. So anyway, he was then arrested on other reasons. No surprise, of fraud or insider trading or something. So I mean, his personality is pathologic. So anyway,
I used to work in pharmacy, and the thing that got me before EpiPens went generic, the 2.5 years that I worked there, they went from being 200 and something to 700. And parents were literally choosing not to buy them for their children because they didn't have the option to.
Yeah, no, it's really awful. As a matter of fact, as far as I'm concerned, they should really have now they've been talking about putting defibrillators everywhere, which I think anywhere there's a big public gathering of people, defibrillators should be available. It's spurred on recently by the National Football League and the guy who went into cardiac arrest due to commotio cordis. And thank goodness, he was defibrillated early and survived. It just so you know that the condition that he had in his arrest, the mortality is like 99% because nobody can get to him fast enough to shock them out of it. So he was like the world's most unlucky / lucky guy in the world. But that's another topic. But I think EpiPens and naloxone and defibrillators should just be one kit that are put into every public space, whether you're at a football or high school, gathering, performance, wherever there's large groups of people. It's not related to like an athlete. Oh, it's the NFL, you should have this available. Where you're much more likely to use it in somebody in the 80,000 people in the audience than you are going to be using on a football player. So anyway, I always think it's interesting that you're saying, oh, we need to do this to protect the athletes. You're never going to use it on the athletes. I mean, it'll be one in a gazillion. But how many people have heart attacks when they gather at 80,000 stands and they're jumping up and down and screaming at the top of their lungs? So anyway, interesting topic. Keisha, did you speak for your topic and for Kaiser Health?
No, not yet.
Okay, go for it.
So when I was looking at it this morning, I thought the like they were trying to make a vaccine for HIV, but the trial failed. I thought that
Mm.
was really interesting.
I thought it was interesting too. Thanks for identifying it. When I looked at it, I immediately clicked on it to see what was going on. So for whatever reason, and I'm no virologist or immunologist, HIV has been a complete nightmare in terms of getting, and they've been working on a vaccine for 20 years. Thank God they have effective treatment right now, and you almost can live a normal life with the current therapies that are out there. And a couple of them are multi-drug, some are single drug. But anyway, bottom line is this one failed. But the one comment that I read in it that was interesting to me was, and this has been Anthony Fauci's baby since day one. HIV has been his baby. He said there are some, even though this was disappointing, he said there's some very exciting trials of new vaccines that are supposed to be very effective. So we keep our fingers crossed, and thank God in the interim, since we have no vaccine, they've figured out very effective treatment modalities. So that's great news for those people who are suffering with it. And then I'm sorry, what your topic again was?
I'm not entirely sure yet. I'm really interested in maternal fetal health, and so I was kind of thinking about like SIDS prevention. But I'm not really sure yet. I haven't done a lot of research yet.
Okay, yeah, and I'm happy to work with anybody, because the longer it's not always easy to choose a topic, and so, but you don't want to spend 2 weeks choosing a topic, because that's 2 weeks lost to research it and move forward on it. So I'm happy to work with you to sort of choose a topic. If you want to use my blog, and I'm sure none of you looked at it, thank God. Unless, do any people have insomnia? Because if you have insomnia, it's a sure cure. Oh, perfect. Kelsey, by all means, just log on to my blog. Within 30 to 60 seconds, you will be absolutely sound asleep. So you'll remember the class for being your best soporific cure for insomnia. But
Unfortunately, that doesn't work. I have tried many things, even sleeping meds don't put me to sleep.
yeah, so it's interesting because I don't sleep well at all, and that's mostly because of all my surgeries and stuff. Anyway, I move my neck, my hands go numb, so I wake up, at least 5 to 10 times per hour, to get into a different position, so my hands, my hands aren't numb. But to me, the biggest measure, because my brother complains about insomnia too, is if you're waking up, if you spend your day sleepy all day, then insomnia is a problem. But some people just don't need a lot of sleep. So if you don't need a lot of sleep, then count your blessings. More time to do fun things or get your homework done or whatever. So, but it can be frightfully difficult to deal with. But give it a try. It might really help. Kylie.
I have like 2 topics in mind. One's like the social class and your access to healthcare, so like the differences in each class, or like how capitalism plays a role in healthcare.
Okay, so again, libraries written on both those topics. So
Yeah.
choose something incredibly narrow. Like if you're going to do access to care, maybe choose a particular community, or find a plan that's innovative in a particular country or particular state. So and so you would Google innovations or novel ways to decrease disparities in care, and choose a very, very narrow program that has tried to address it using a certain technique, and see whether it can be expanded, if it's reproducible, if it's unique to that particular geography.
Could I like compare America to another country?
Yeah, again,
Maybe, I don't know. I'm thinking. I'm sorry.
Yeah, no. It's just, again, tomes of material on it.
Yeah.
You might want to compare 2 very specific programs, like a very narrow program in one country versus another. That would be really interesting.
Just based on whatever I get for research. I don't know yet. I've like touched both topics already, but I want to go deeper
Yeah, no, perfect.
in
And
other
deeper,
classes.
yeah, I know. Deeper is key. That's the key to make this. I'm trying. So when I'm sort of asking you guys to narrow it down, I'm trying to make your lives easy. Because otherwise you're going to be, you'll write 10 pages on the previous history of this situation, and then there'll be nothing to talk about in terms of steps forward, difficulties and advantages of different programs.
Yeah.
Because, no more than a third of the paper should be sort of going over the existing program or what the status quo is. And most of it should be analysis and how it can be moved, how we can move forward on it, and strengths and weaknesses. So that's key. Any topic in Kaiser Health News that
I was on like the actual website this morning while I was in another class. Well, that's funny me. I just saw that the first thing's the $30 million gift for addiction treatment centers. I'm really into that stuff, and that was really interesting to me. I didn't read it yet, but like I read the little blurb.
Well, yeah, they're all just little blurbs. That's why
Yeah.
it's so quick to read through them. So, it raises the whole issue of private versus public funding of public health. And there was
Yeah.
another one. Oh, this actually has to do with, which is a public health issue as well, but sort of indirectly, immigrants. That there was a new endeavor to allow private individuals to sponsor immigrants who are illegally in the United States, which I thought was a nice effort to get the government out of it and get people who want to, sponsor illegal immigrants who are in the United States and in the process of being, assessed for their status. So that was interesting as well.
Yeah,
Okay,
that's interesting.
Amanda. Ooh, no Amanda. Maybe Amanda isn't in this course. Is Amanda Kime in this course, or just say no, she's not, or?
I mean, she's been in other public health courses, but I don't know if she's enrolled in the class or
I
not.
think she's probably not. I'll just put a little X next to her name, sorry. Because I've got 1, 2, 3, 6, 7, 8. Yeah, I've got 13 people, so she probably dropped the class, saw my syllabus and said, forget that. John.
I haven't looked at the Kaiser stuff yet.
Okay, so we just do that. Have you signed up for the email?
Yeah.
Okay, great. So yeah, it comes really early in the morning, like 6:30 or 7. So it's quick. And do you prefer Jack?
Yeah, please.
Yeah, sorry. Just
Thank you.
cross that out. I just saw that there was discordance between. And topics?
I've studied like alcoholism in the past, specifically first responders, but
Yeah, well, so that's narrowing it down significantly. So what should be the mechanisms in place for first responders in terms of alcohol? And one of the interesting things is how often do you know if alcohol is a primary or a secondary effect of why the primary responders are coming in? But yeah, has some potential, especially if you can narrow it down dramatically. Olivia.
I've looked at a couple different things. I've looked at a lot of the abortion stuff on Kaiser Health. Also looking at like they had a couple about like women with excess nausea or bleeding and pain during their pregnancy. But
Yeah, I saw that as well. That was interesting. Yeah.
So, I mean, like you would think that if they're banning abortion in these states, and they would try a little bit harder to keep these pregnancies like healthy. So I just kind of thought that was a little odd that there was still like a lack of care there. And then I'm also really interested in like disabilities rights and looking at care provided for the disabilities or the population for people with disabilities. But I hadn't really seen anything on Kaiser Health specifically about that. So I would have to do a little bit more research.
Yeah, choose one or the other. There's a ton of stuff. Now that Roe's been overturned, there is just a plethora of information on the impact of it. And you can't just choose Roe's been overruled. What are the impacts? I would choose like the impact of that on IVF or something even more narrow in scope. I mean, one of the big topics that's come in is what do you do now with frozen embryos? I mean, my twins are IVF, and I was just thinking, this is a nightmare. I mean, to do IVF in a state that like tries to put you in jail and makes your neighbor the watchdog of it. I actually have not researched that at all, but it really becomes. I mean, how do you run an IVF clinic? I mean, the bottom line is, I mean, you're obligated in perpetuity to keep all embryos frozen. I mean, it's really awkward and difficult. So anyway, choose either one of the topics is great, but just choose something incredibly narrow. I mean, and again, obviously disability, I'm disabled, so it's of interest to me. But I mean, I've been teaching Roe for 35 years, and I've been teaching for 35 years. It's just a matter of time because it's going to be overruled. It's the right decision for the wrong reason. And when you have the wrong reason in the decision will eventually become overturned. So interesting topic. Thanks. Sydney.
So I was looking on the website and there's like a whole tab for environmental health, and that's what I was interested in for like my topic. And so there was one that I was looking at on like how living in a city like negatively can impact your mental and physical health from like being awake and all the city noise and everything. And I thought that was interesting. And I also saw the two articles that Liv was just talking about in women's health, and I was like, I was just reading those ones for fun. I don't know if I want to do it about that, but
Yeah, no. I mean, and that's what's so nice about Kaiser Health News. But get the newsletter, because Kaiser Health has an incredible website that covers all the different topics. Get the daily news feed. That's what I'm hoping you'll look at, because otherwise you could spend hours on the Kaiser Health News website, because it's got just tons of great material on it. But just use the news feed, and then you can choose your topic independent of Kaiser Health News. If people use it as an inspiration, great. If they want to, the nice thing is many of the topics in the Kaiser Health News feed are extremely narrow, and that makes your job easy. And you sort of have a starter, and you're able to do a deeper dive into it. So that's great. Megan.
Hi. I am like very interested in the mental health like portion of it all.
So anything specific?
Well, my capstone's on PTSD and firefighters. So like
now that's a great narrow topic.
Yeah,
Perfect.
so that's very like interesting to me and like close to home. But I'm also very interested in like postpartum psychosis.
Huge
And
problem.
like the lack of resources available to women in the US compared to other countries.
That's a fascinating topic. As a matter of fact, one of my close friends, I talked with him on Zoom for about an hour every Thursday morning. And we were talking about maternal mortality in the United States. Is anybody aware of whether it's a small problem, medium problem, big problem? Yeah, go for it. Olivia.
Oh, I was just saying I know like both maternal and infant mortality in the US is a fairly large problem. I don't know that much to elaborate, but
yeah, no. It's a gigantic problem, and what's so scary is that resource poor countries do much better than we do on maternal and infant mortality. It's beyond scary. So I was talking with him about it. That's why it's such an interesting topic. And you brought up postpartum psychosis. And the big issue is not psychosis, even though there's psychosis there, but it's postpartum depression is the huge thing. So when I sent him an article about how obscene the maternal mortality is in the United States, and when we both did a drill down on the data, what was the overwhelming disproportionate amount of deaths caused by of maternal mortality? You get to guess because I asked you the same question about guns.
is it suicide?
It's suicide. It's really sad. So yeah, it's a gigantic problem, and the overwhelming disproportionate, and I don't know if that's just a problem in the United States or not, but it's an interesting topic. I would narrow it down even further. But like an really interesting topic. I find all the topics interesting, so sorry if I go on and on. But postpartum suicide as a very narrow focus would be super cool. And how it compares internationally, and if there are any programs out there to address it, because there's a lot of prevention you could do in that regard. So interesting stuff. Geez, our 45-minute break is due, but this was okay. Do people think this is a waste of time or rambling? We won't be talking about papers once you choose a topic that much. And we covered a bunch of interesting topics, I thought, but if you're like, God, this class is all over the place, I don't want to do this, I'm happy to make it more structured. Has this 45 minutes been helpful to you in sort of exploring interesting and current topics? Or is it like, oh my God, no, this is terrible. Let's have sort of more structured discussion. And because it's easy for me to just, say first 45 minutes is on malpractice, second 45 minutes is on burnout. But the next half hour, the next 45 minutes after we take our break, I'm going to focus. I'll probably choose one of those two topics and just go over it in a little bit of detail. But again, none of this material, just so you understand, none of this material you're responsible for. There are no quizzes on it. There's no midterm on it. There's no final on it. So I just want this to be open discussion. Wow, that's an interesting topic. But if you're like, this guy's crazy and enthusiastic, but I'm not learning anything, I'm not going to go there. I want this to be a good class for you guys, something you look forward to, like logging on or interacting with. So how many people want more structured lectures? Okay, even though you're not gonna get tested on any of this stuff. So that's a third of the class. And how many people are happy with the way it is? Because then I can find out if there's sort of no opinion. So okay, so the remainder of the class actually came out. So you know what, we'll do a little of both. So what I'm going to do is the way I was planning on doing it anyway was half the class on sort of free form, what's in the news, let's talk about it briefly, and so you're aware, and again, so many things to analyze. And the second half will be a much more, so what I'll do is I'm going to talk about, you take your 5-minute break and I'll surprise you with what I'll talk about as a more structured lecture for the second half of the class. So I will see you just before 1.
I just have a quick question about the paper.
Sure.
So I was looking on Moodle and there wasn't really like any like I don't want to say requirements, but like, is there like a page requirement that you specifically like
I
want?
thought I put 3,000 to 5,000 words, so whatever, and that's like 10 pages.
Okay. All right. Thank you.
No problem at all. Perfect. For those of you who want, the topic for the next 40 minutes will be medical malpractice. And I could spend every class on medical malpractice because there's so many different aspects of it, from product liability to informed consent to all the specifics in health law for medical malpractice. But we're going to talk about general medical malpractice now. And again, I know that a lot of people have expressed interest in it as a topic to go over. And I think it's important to understand if you're, what you're at risk for. You're in a career where you're at risk for a lawsuit. So the first thing that I typically get asked is, can I get sued for, and they mention a scenario. So how many people think that there's only a very narrow number of things you can get sued for? Or there's a lot of different things you can get sued for? So we'll ask a very pointed question then. Can you get sued for having an ugly colored tie or dress or hairstyle? I don't want to make it sexist. Can't get sued for that. How about an offensive perfume or cologne? Yeah, so everybody kind of saying, yeah, those are ridiculous lawsuits. Here's one of the benefits and one of the drawbacks of the American legal system. You can get sued for anything, absolutely anything in the world, and then you have to hire an attorney and go through all this rigmarole. The question has never been whether you can get sued. You can get sued for anything, including your hairstyle, which somebody can say shocked them into catatonia and created PTSD because of the color of your hair shocked them so much. The issue is whether you're likely to succeed. And, so how many people have heard of the lawsuit where the woman said she had either a CT or MRI? I think it was a CT, and she lost her psychic abilities. Anybody hear about that? Yeah, that you can Google it. It was an actually filed lawsuit. The ones that shock me are the lawsuits of spilling hot coffee in your lap and then being surprised that you got burned. and potentially winning a verdict. Do people remember that one? I think it was McDonald's. Somebody got literally sued. I think the jury actually awarded the person something. I don't know if it was reversed on appeal, but God forbid you spill a hot liquid on yourself and you're surprised that it was, that causes burns. So anyway, just there's a lot of crazy lawsuits out there. The vast majority end up getting reversed on appeal if the jury goes the wrong way in terms of just common sense. So you can get sued for anything. And in healthcare, can nurses get sued? Absolutely. And can pretty much any healthcare professional get sued, whether you're a respiratory tech, physical therapist? Yeah. So the question is, if you're concerned about whether you can get sued, yes, you can. And then, so again, the issue is you should understand what is required to get sued. And so the elements of a lawsuit. So I'm going to ask you a very generic question. What do you think the top 5 things that cause lawsuits is?
Missed medical diagnosis.
So misdiagnosis is very common lawsuit. How many people know they've been misdiagnosed? So it's a very frequent problem. I think a lot of people are misdiagnosed and it's never suspected because eventually they get the right diagnosis. But there's an entire, if you guys are ever interested, there's about a 500-page thing on misdiagnosis. I used to be an associate editor for the journal. It comes out of Germany called Diagnosis. And it's just a huge problem of great interest and very difficult to solve. Maybe AI will be a solution in that regard. So misdiagnosis is one of the reasons that people get. But when a patient has an experience, what is the most likely thing in patient experience that's going to cause them to contact an attorney?
If harm is done.
All of you, I'm going to hear all your answers.
If harm is done to the patient.
So harm. Anybody else? I know Olivia said something.
Neglect.
Neglect.
I was gonna say like a break in HIPAA.
Okay, HIPAA. So that would be a HIPAA violation. So that's clearly a reason for a lawsuit. So I will tell you overwhelmingly, and this is based on 35 years of experience in this, that the major cause of lawsuits and patients going to see an attorney is unexpected catastrophic medical injury. Do you think that's true even if no mistake was made, that they'll go see an attorney?
You say that one more time, please.
Unexpected catastrophic medical injury.
You give maybe like an situational example.
Sure, yeah, you go in to get your hip replaced and you die on the operating room. Nobody expects to die getting their hip replaced. So is that person likely to go see an attorney?
No, they're dead.
Well, not that person.
Their estate.
Wait a minute.
Well, that's fine. Let's say they have a horrible
I
stroke.
mean, likely
Let's
there
just
to
change the
go.
scenario. You go in for hip replacement, you have a heart attack and a stroke, and you're in a chronic vegetative state, or you're profoundly neurologically impaired.
I mean, more likely what's to happen is they're going to do an investigation, because if the person also wasn't diagnosed with something and no one knew, or someone didn't put it in the medical chart, or it got left out of a chart, then if they knew about it and they didn't provide the right steps throughout the procedure, it's more likely they're going to sue. But if it was something totally unknown, no history of, couldn't control, they'd probably be less likely.
So I guess the issue is, do patients know whether a mistake's been made? Do patients know what is expected or unexpected in terms of an outcome typically?
I don't think everyone always knows unless they're in the field, because I feel like doctors talk to patients more and I guess I don't know what people call doctor words, not person to person.
Sure.
So when they go through that, they don't really understand what's happening. I mean, I experienced malpractice. My family never sued because my mom worked for them, and then it was this whole thing, and it was a lot. And then she also was So I had my appendix out and they nicked my whole intestine and I became severely septic, but they never knew they nicked my intestine for 4 days. So then I coded, like died on the table, and then I came back to life, obviously. But then no one ever sued because it could have happened anyways.
So I'm sorry for your experience. Obviously,
No, it's fine.
no adverse effects from it, and makes you a better health, better person to be in the healthcare scenario.
Yeah.
Because of the experience. But so what percentage of healthcare encounters lead to an adverse event, meaning unexpected or, not part of the course? Is it, you can raise your hand, 10%, 20%, 30%, 40%, greater than 50%? You guys are good. Yeah, it's around 40%. And what percentage of those are preventable? 5%, 10%, 20%, 30%, 40%, 50%, greater than 50%. So overwhelming, this is all data that's sort of made up because you have to define an adverse medical event. People always say, oh, that's a known complication. And we should talk about that briefly as well. That's a known complication of the procedure. So that's not an adverse event. And then there's the whole issue of identifying what constitutes reversible or preventable. So the numbers are all over the place. There's probably about 50 years of data on this, 40 to 50 years of data on this. And it's about 40% adverse events, and of that 40%, 25% are considered reversible, but the numbers go up and down. It's quite variable. So bottom line is errors and oversights are just all over the place. So of 100 errors that take place, how many end up in a lawsuit? So I'll ask again, less than 5%, 10%, 20%, 30%. Yeah, it's like probably about 1%, because the burdens for filing a lawsuit are gigantic. One, tons of mistakes take place and nobody ever does anything about it. One, they don't know about it, or even if they know about it, they don't do anything about it. The other thing is, if you have a small mistake that leads to, let's just say, half a day, your discharge from the hospital is delayed by a few hours because somebody forgot to give you the right dose and they had to keep you there to give you the correct dose. And it was an obvious mistake, complete oversight. Nobody's arguing about that. Do you have a lawsuit there?
You could have one, but it depends who actually goes through with it.
You listen to me carefully. You can sue for anything. The correct question is, are you likely to succeed? Will an attorney that you go to, and they said they admitted they made a mistake, and it took me, I had to spend 3 hours longer in the hospital. Will a plaintiff's attorney take that?
I would say no.
And why is the answer no?
Because it's not winnable.
So I'm telling
3
you,
extra hours instead of like having like your leg taken off because of
yeah, and you hit the nail on the head, Kelsey. That's exactly right. There are no damages. When your leg's taken off, that's damage. You lost your leg, you're disabled for life. If your discharge was delayed 3 hours, what are they going to give you? $15? Oh no, you make $100 an hour. We're going to give you $300 for your lost time. So the reality is it's all, and that's why when I said, what's the leading cause of a lawsuit, and from the patient's perspective, is unexpected catastrophic medical injury, because it's unexpected. And they're going to immediately say, people's knee-jerk reaction is, who screwed up? So is the defense, well, I'll give you another example. Is the defense that it's a known complication? Let's say you go in to have your appendix removed and you end up with a hemorrhage. Is hemorrhage a known complication of surgery? So that means everybody who hemorrhages during any surgical procedure doesn't have a lawsuit? So Kelsey, you saying no, they do, they say they could have a lawsuit. What would be the situation where they could? Doesn't the doctor or the surgeon or the anesthesiologist just say, hey, everybody knows we were on the informed consent, it says, infection and hemorrhage.
If they have a history of it already before the procedure, or also if the doctors or nurses don't fully inform them to all the information that is provided, then yes, they could have a reason to sue. But if they're
So-
given the information and they hemorrhage, it's not something that like could necessarily be controlled.
Okay, so, and now we're gonna start going over the elements of malpractice. So the answer is, might be a little bit different if I told you the surgeon who's doing a colectomy and the patient has a massive hemorrhage and either has a stroke or, ends up in the ICU or whatever, or multiple transfusions. What if I told you that surgeon has 100 times more hemorrhages than the average qualified surgeon would have? Is it malpractice now?
Technically speaking, yes.
Yeah, overwhelmingly, because the way you determine whether it's malpractice is, did they comply with the standard of care, which is generally accepted medical practice. So that just allows me to dive into the 4 elements that you need to prove to establish malpractice, whether it's nursing malpractice, legal malpractice. The 4 elements are, and you can write this down if you want, or you can rewatch this video 100 times, but I'm never going to quiz you on it. I'm just doing it so you're educated on it and understand it when you're out in the world practicing. It's duty, breach, causation, and harm. Duty, breach, causation, and harm. And that's what is required to be proven to show negligence. And that's separate than, somebody mentioned lawsuits for HIPAA and lawsuits for fraud and abuse, which are separate issues and have nothing to do with duty, breach, causation, and harm. So duty is that the person who's caring for the patient has an official relationship with that patient. Like, I'll give you an example. If I go to a cocktail party, or whether it be a nurse, a clinician, an NP, a PA, whatever, and the person who's a person I have never met before says to me, I am having crushing substernal chest pain. It's radiating down my left arm. It's radiating up to my jaw. I have a sense of doom. And these are the exact same symptoms I had when I had my first heart attack. By the way, for those of you who don't have a clinical background, I just described the classic symptoms of a heart attack. Those are the class. I mean, anybody tells you, I feel pressure in my chest, radiating down my left arm, going up to my jaw, I feel nauseous and vomiting, I have an impending sense of doom. Do not pass go, do not collect $200. 911, get to a hospital. So those are just classic symptoms for people who are versed in clinical medicine. So again, EMT, PA, nurse practitioner, doctor, nurse. So I'm at the cocktail party. I've had a cocktail or two, whatever. And I go, I don't think it's anything. That's not a big deal. I think you're gonna be fine. I think you're gonna be fine. So it's all good. So is lawsuit?
I mean, you weren't his doctor, you were just a peer at that point, so I would say that you probably couldn't sue.
Anybody else? Thank you, Olivia.
I think you could, because you had the knowledge to help and somebody described a problem and you said, you'll be fine, don't worry about it.
So you're absolutely, both comments are spot on. And I'll tell you why. Olivia, you're right. There is no relationship. There's no formal relationship between, you're just 2 people at a party. Even if you identify yourself as a doctor, there's 2 people at a party. Keisha, you're right in that, is there a reasonable expectation that if I ask a doctor for medical advice, even if they're not my physician, that I would get reasonable medical advice? But I'll give you the following example. If you are the world's best swimmer in the world and you see somebody drowning and they're 15 feet offshore and you are absolutely fit and able to swim and you could easily go out and rescue them, do they have a law? Can they sue you for not rescuing them? Yeah, there's no duty to rescue. And there's no duty outside of a physician-patient relationship or clinician, whatever. I don't want to make this doctor-centric, who cares? Anybody who knows how to take care of people and has special knowledge without that. So how do you prove that there's a physician-patient provider? Sorry, I keep saying physician because that's a lot of times I'm teaching medical students and stuff. How do you prove that there's a provider-patient relationship?
Most of them are like signed. So like every time you go to a doctor, you fill out forms, and that basically says this person has the right to treat me. They can treat me. I consent to their treatment. And that basically covers that doctor for a lot of stuff. Like there's a lot of that like people don't even read. They just look over it. So like some of the things are you cannot sue if this happens. You cannot do this if that happens because you signed this form, whether you read it or not, you put your signature there. There's been cases where someone's drowning and someone saved them, and when they woke up, they sued that person for saving them because they touched them. And it was a guy and she was a girl and he performed CPR. So it's
That's definitely sexual assault. Trying to save somebody's life. Holy moly. Yeah, now that's why it gets to the earlier question I asked. Can you sue somebody for fill in the blank? And the answer is yes. And those cases are all losers. I mean, it's just, a jury looks at that, a judge looks at that and they go like, oh my God. That reminds me of the first time I heard of the sniff test. I was in law school and one of the professors said, and this is not a true test, okay? It's just gut feeling and common sense. So, somebody made some comment that was pretty outrageous. And he said, does that pass the sniff test? And he goes, the sniff test is just common sense. If something is so palpably outrageous and so ridiculous, then it doesn't pass the sniff test. And I think, sort of common sense goes a long way. When something makes no sense, go with your instinct and then further research and verify. So yeah, it's pretty ridiculous. Anyway, so signing the forms, going to the doctor's office, them accepting you as a patient, well, that's pretty clear. Anything else that establishes a physician-patient relationship? Like if you're sitting in a waiting room of an ER and you've checked in, is there a physician or is there a professional relationship?
yes. You're not, if you're like in the ER, you're not signing for a specific doctor, you're signing to receive care, whether that be through a nurse, a physician, a med student, whoever is able and eligible to provide care, you have consented that that whole building and who works there with the qualifications they have can give you treatment.
So that's absolutely true. You've established a hospital patient relationship. There's every reasonable expectation. So what's the one thing as you're sitting there in the waiting room that is crucial that every hospital and their employees do before they sit you down and say it'll be 3-hour wait?
They take your vitals, they ask you what's wrong, and they ask for a medical history.
So what does anybody know what that's called?
Triage.
Triage. So that's exactly correct, Kelsey and Keisha. You have to triage the patient because you need to establish whether this is truly an emergency. What percentage of people going into the ER have a true medical emergency? Okay, poll time.
It's pretty small, right?
Yes.
It's what are they going to the ER for versus what could they have gone to an urgent care for? If you have heartburn, you can go to an urgent care if you have frequent heartburn. But if you're having symptoms of a stroke, you need to go to the ER. If a baby has a fever higher than 102, I think it is, or 103 for any given amount of time, that's an ER trip. If they're just crying necessarily, that could be an urgent care trip or a trip to your primary care doctor. It's what is the difference between the symptoms that they're coming in with? A sprained ankle isn't necessarily an ER, but a broken one is.
And how do you tell the difference?
Many individuals have to use their best judgment. It's also more of like, are you going to die? Could this provide physical complications to you in the long term. So like if your bone's clearly sticking out of your leg, yeah.
That's easy. Compound fractions are ERs, but distinguishing sprains for a layperson, sprains from a break, is not necessarily. And your assessment, while correct, is that prospective or retrospective?
Kind of both. I mean,
Yeah,
it depends on what you have. Like if you're an adult and you have a fever of 101, you don't necessarily need to go to the ER. If it's going to be over 103, 105, then yes, because that's going to fry your brain, like you need to get treatment. But if you have the flu or a cold, you could go to urgent care.
So the problem is all the scenarios you describe are very fact specific. Does everybody who has the flu, which means you feel like crap, you have no energy, you have fevers in the 103 to 104 range, should they all go to an ER?
Not unless the fever persists for, I think it's 48 hours, they normally say.
Probably even longer than that, because the normal course of the flu is, oftentimes 5 to 7 days. So, but yes, one of the criteria for saying you need to see a clinician, not necessarily go to an ER, is persistent fever. Especially if you have same-day appointments with a doctor, you can just go to your primary care if they provide same-day appointments, which many practices do. But the bottom line is, it's not easy to tell. So if you do a retrospective analysis, and this discussion started by me asking you what percentage of ER visits are true emergencies, medical emergencies, that there's a threat to life or limb. So we'll just do the poll: 10%, 20%,
What was the
30%.
question?
What percentage of ER visits are truly life or limb threatening, meaning they should be seen urgently? So 10%, 20%, 30%, 40%. You guys have great instincts. So yeah, it can't be more than 20%. It's really, really, really. So 80% of patients can just be seen as outpatients. And so it's really crazy in terms of why do you think hospitals encourage people, or primary care docs who are, say, oh, I've got whatever, had a fever for 4 days or 5 days, they say go to the ER. I'm having heartburn, but I want to make sure it's not a heart attack. And they say go to the ER. And why do hospitals say, yeah, if you have symptoms, we're here to serve you, come to the ER?
Because you can't really triage somebody over the phone necessarily. And if you haven't, like as a provider, if you haven't laid eyes on them and it could be a symptom of something bigger, I mean, you want to care for your patient, but also you want to avoid liability.
So liability is one issue, convenience is another. And from hospitals' perspectives, what do you think a visit to an ER runs in terms of charges? So we'll do the poll again. $300, $500, $800, $1,200, $1,500, $2,000. God, you guys are good. So I went in, I was the chairman of radiology at Cape Cod Hospital. I needed an MRI because of all my neck problems. I said, but I need a report. I would get MRIs all the time, but I needed a formal report to go into the chart. So they said, look, for you to get a formal report, we have to, quote unquote, enter you into the ER. And, you need to be evaluated by an ER doctor. And I knew all these guys, they were my friends. I said, yeah, do whatever you want. I don't care. What was it? What do you think Blue Cross Blue Shield got as a bill for that ER visit, which was a joke? It wasn't an ER visit at all. It was just, I needed to register to get a formal report for my MRI.
$4,000.
So whatever the rate was, they paid $2,000. But you guys are all right, somewhere around 15 to 2,000. So, but are hospitals happy to have you come to the ER?
Yeah.
Especially if you have good insurance. Yeah, no, it's become an issue recently because, there's such a backlog and there's such an overwhelming rush, especially with COVID, that, now they're saying we need to decompress ERs. But historically, does the hospital care if you have a non-urgent, you're triaged appropriately, you have a non-urgent medical condition? Do they care if you wait for 15 hours?
Nope.
No.
They could not care less. They're going to get their $2,000 whether they see you in 10 minutes or 10 hours. So they're delighted, and so and it's again, it's really hard to know in advance what you've got. But I mean, they could at least do, and this happened during COVID, pick up the phone, call the ER, and see if they think you should come in. Because people would get a fever of 101 and they'd say, oh, I think I have COVID, I'm running to the ER. And they'd say, no, that's crazy. If you don't have symptoms beyond just fever, like shortness of breath or chest pain or, discoloration of your lips or your fingernails or something indicating a serious problem, they were saying, yeah, just, schedule with your primary care, the ER is totally booked up, we're overwhelmed with business. So anyway, the reason we were discussing this was to establish whether there's a physician-patient relation, clinician-provider-patient relationship, and that's duty. And the answer is there's an established relationship that would be recognized as a relationship, and probably one of the most important criteria as to whether there was a relationship is, what do they do to you as a patient after they finish seeing you?
They kind of just send you on your way, and you don't really get any people coming in to check on you after.
Yeah, that is absolute routine, but what do they always send you that's even more painful than the condition itself in the mail?
Oh, the bill.
So if you've ever sent out a bill, you have a relationship. So that's one thing that's an important sort of criteria. So that's duty. And again, as at being in the healthcare provider thing, you will find that you get these curbside consults all the time. And I would get curbside consults all the time. And I would just say, based on my training and background, but I'm a radiologist, so don't trust me. And if you have any real concerns, always see your own doctor, nurse, PA, nurse practitioner, whatever. So that's duty. So breach, what do people think that breach means? Since it may be just based on what it means in lay language. What does breach mean? So duty, breach, causation, and harm.
Like enter?
Oh, so yeah, if you breach the hull of a boat, what are you doing?
The hull of a what?
Of a boat. If you breach a space, what do you know the use of the term breach in when it comes to sort of a confined area, whether it be a boat or a property or a home? Maybe you don't.
I thought it was enter.
Well, it actually means sort of to violently enter or to render asunder. Somebody can Google it and we can get the formal definition. Do the law definition, which is Black's Law Dictionary. But basically, breach means you're not doing something right. There's an established way to do it, and you're breaking the established way to doing something. So meaning, and again, I mentioned earlier that you've got to do, you have to comply with generally accepted medical practice. So if the average qualified practitioner, and these are buzzwords, when you hear generally accepted medical practice, they're the buzzwords that lawyers use. And the average qualified practitioner, these are the buzzwords that lawyers use and have secret meaning. So breach means that you're not complying with what the average practitioner would do. So how would you establish that in a court of law? So we've established that there's a physician-patient relationship. You say the doctor did something or clinician did something they shouldn't have done. How would that be proven to a jury?
I feel like the only way, or I'm sure this is wrong, but like if whatever kind of nurse or whatever other supporting staff is in that OR or wherever you're, like, there has to be someone else that saw it, in my opinion. I feel like that's hard to prove without somebody else.
No, I mean, actually, the medical records are pretty complete. So there doesn't need to be physical evidence of somebody else watching you do it. Just go to the medical record and it'll say they gave antibiotics, they didn't give antibiotics, they gave the right dose, they gave the wrong dose. They missed the diagnosis. So you can there's a paper trail, unlike a car accident where it's he said, she said. In healthcare, there's almost always a definitive, and that's why there's a whole other discussion that can happen with the discussion of medical records and what to put in the medical records and what not to put in the medical records. But the key there is that in terms of breach is how would you establish whether somebody did something right or not?
asking another clinician what they would have done in the same circumstance.
Exactly. So that's called expert testimony. And expert testimony can be another person in the same specialty saying, nobody does it that way. That was crazy. Or go to the literature. The literature says these following symptoms require this type of imaging and this kind of treatment and this kind of investigation, or recent articles. So expert testimony. So that's duty. And then breach is complying with the standard of care, which is established by typically, again, expert testimony, duty, patient-physician relation, patient-provider relationship, breach, violation of the of the standard of care. And then there's causation and damages. So we'll do causation last, but let's do damages. Okay, so seems pretty intuitive. You got hurt. We talked about earlier in the class that if your diagnosis was, if your discharge was delayed 3 hours, that's not a whole lot of damages, but there certainly are a whole lot of damages if you lose your leg. And I think somebody brought that up as an example. So I'm going to give you a scenario, and you tell me if there's a good lawsuit here. So patient goes into an emergency room, is evaluated. The patient says, this will sound familiar, I'm having crushing substernal chest pain radiating to my left arm. I have nausea and vomiting, and it feels just like the previous heart attack I had. And the nurse says, or the person doing the triage, whoever that is, says, don't think you got anything, but we'll have the doctor see you. Patient goes in, sees the doctor within 10 minutes or 5 minutes. The doctor says, I think you're okay. I just did your EKG. It looks good. I think you're fine. See you later. Guy goes, this is freaking crazy, and literally just drives across the street, because there's another hospital right down the street. And he says the exact same thing he just said. He said, oh my God, you're definitely having a heart attack. They send him up to the cath lab. He gets his balloon angioplasty, and he's discharged within a day or two, and he's fine. So does that patient have a great lawsuit against that first ER that completely blew the diagnosis? Well, yeah, everybody says, yeah, you got it. That's just freaking crazy. Okay, so let's go through this. Is there duty? Yeah, absolutely. Went into the ER, was examined. I'm sure they sent them a bill as well. Is there breach? Did they comply with the standard of care? There's about 1 million doctors and experts who are going to say, no, they didn't comply with the standard of care. So lastly, are there damages?
I mean, there could have been if the patient had just gone home instead of going to check with the other hospital first.
So yeah, there could have been, but could have been doesn't count in a court of law. So are there damages? What harm did this person suffer?
Not being treated right on time, having to spend more time, and then spending
How much do you think he's going to get awarded, or she's going to get awarded for a delay of diagnosis of 10 minutes when he or she recovered completely uneventfully? And what would had the first hospital made the correct diagnosis, what would they have done differently than the second hospital? They would have done exactly what the second hospital did. So here's a great example of why malpractice in the tort system just doesn't work and is terrible. You can engage in the worst malpractice known to man, meaning breach, deviation from the standard of care, but it's not true malpractice because there was no harm. No malpractice attorney would take this case. As outrageous as it is, no malpractice attorney would take this case because there's no damages. They will take every case with massive damages, even though nothing wrong was done, because it tears at the hearts of juries. Juries hate to see people who have horrible, unexpected, catastrophic medical injury, no matter how smart and good the caregiver was, go home, go home with not a dime in there. They may be blind, even though nobody did anything wrong. They may have had a stroke. They may have lost a limb, even though nobody did anything wrong. But juries are loath to not be sympathetic to catastrophic injury, especially in children. Monica, did you have a question? You can say no if you didn't.
Oh, I was just shocked that in the case that you said, no jury would take the case.
because
The jury'd be happy to take the case, and then they'd be directed by the judge to, there's no damages. There, you can't, I mean, you have to come up with some damages. Otherwise, there's no case. I mean, it should be reported to the medical board. It should be reported to the quality and safety officer of the hospital, but there's no malpractice suit here. And, you know, so that's duty, breach, and damages. You have to understand that they're damages, and causation just means that the malpractice caused the breach. I shouldn't say malpractice. The breach is the cause of the damages. So let's just say, I'm trying to think of a good example on causation so that it makes sense. Let's say a patient goes in with a broken, they've sprained their knee in their lower leg. They're not sure whether it's broken or not. The patient gets an x-ray. The x-ray is misread. It's read as no fracture, but there is a fracture. So, and every expert would say that fracture should have been detected. And then they go home and they start getting short of breath, and they have a stroke. And when they get admitted to the stroke, they realize they made a mistake on the leg fracture, and they say, oh, you know, let's put a cast on, and they treat the stroke appropriately. So do you have a lawsuit, or do you not have a lawsuit? Duty, breach, causation, that the malpractice caused the injury and harm.
I would say yes, because it should have been read correctly the first time.
So you're falling into the problem of terrible medical care doesn't create a lawsuit. It's so duty, we know there's duty. Went to the hospital, had an x-ray, so there's clearly a relationship. Breach, yeah, everybody, I gave it as part of the scenario that every radiologist would say, yeah, this should have been read correctly. So, and the harm is what? Stroke? Okay, so does misreading, and this is what causation is. Does misreading the fracture in the lower extremity cause a stroke? And the answer is no. So that's what causation is, that what mistake was made causes the subsequent harm. So he would have, if the diagnosis was made correctly, he would have gotten a cast and gone home. And you know what would have happened when he went home? He would have had a stroke. So there is no causation between it. So duty, breach, causation, harm. Happy to answer any questions about that, and or anything else that's going on in the class.
So would things like hospital-acquired infections fall under causation then?
So again, it's very, very fact specific. So if you could say, certainly a hospital-acquired infection is an adverse event. So you clearly throw that in that 40% of encounters that lead to an adverse event. The question is, does is there something that, like, is there ever a hospital that doesn't have hospital-acquired infections? No, they all have hospital-acquired infections. The question is, if the hospital you went to has 10 times the rate of hospital-acquired infections or ventilator-associated pneumonias, then there's probably a systems problem or an error going on. So there could easily be malpractice. But since we all know you can't reduce hospital-acquired infections to zero, it's very, very fact specific. So duty, yeah, it's there. Breach depends if whether you can find an expert who's willing to say, yeah, this is not the standard of care. Causation would be, again, related to the circumstances that caused it. But if you're in a hospital and you get an infection, that's hospital-acquired infection. And then the damages are whatever damages you got from the hospital-acquired infection, whether it be sepsis or any other problem, prolonged hospitalization or stroke or heart attack. Is that fair? Cool. Jenny?
Okay, so I'll try to make this quick, but my brother had a stroke. Mind you, he's he was 25 when this happened.
Mhm.
And he had to go to Boston for everything because he was at Lowell General, and they were like, he's having a stroke, he's dying, he needs to go to Boston. So we went to Beth Israel, and they pretty much told him that he had a cavernous malformation, but it'll go away in 2 weeks, that there was nothing they could do. But then he was progressively getting worse. And like it was to the point that he couldn't talk. Like he had to get like a feeding tube put into him, like this whole thing. But then they told him to go see like a cancer doctor because they were like, we think he could have brain cancer. When they've done like all these scans, they did an MRI, CT, like, and the doctor pretty much told him that he was going to die in like a month or two. But then he also recommended to get second opinions. And like the other doctors, they went to like Mass General, Brigham and Women's, and they all just laughed at that cancer doctor because they were like, he doesn't have cancer. Like, why are they telling him this? But the doctor at Brigham said that like, oh, I can do this surgery. He definitely does have a cavernous malformation. But my mom went to a malpractice lawyer, and they said, even though at first they did misdiagnose him, since he had the surgery and that he's like pretty much at 100%, like if you had a conversation with him right now, like you would never know that he had all this happen to him. So I'm just more confused in like the medical misdiagnosis aspect of it, of why that couldn't have been a case when there was like clear evidence that he was declining before the surgery.
So again, that's the classic example, and it really just reinforces what I've, the example I gave of them completely misdiagnosing the acute heart attack, ended up getting surgery in a timely fashion and ended up with no deficit.
Mhm.
Horrible care, no damages, and they won't take cases. Plaintiffs' attorneys spend a lot of time and money to get high value damages so they can make a lot of money because they collect 40% of it. So, it's not, again, without again, that's why I said the first, oh, by the way, the other two things that I talk about that cause so catastrophic medical injury is 1, 2, and 3 on the cause. The second is the pissed off patient. If you're pissed off, you're very likely to go see an attorney, and then the attorney will screen whether there's enough damages and breach of the standard of care to make it worthwhile. And the last one is medical error, because so many medical errors occur that there's no lawsuit. So it's the least important. So yeah, I mean, you gave the perfect example of what I gave an example of as well. It's just medical malpractice is one of the worst ways to say we enhance the quality of care using medical malpractice. It's terrible. Olivia.
Can you plead emotional damage, or does it have to be physical?
Oh, you can. They always do. And there's an entire tort called intentional infliction of emotional distress. So you can say pain and suffering. It just doesn't go that far without hospital bills, or how much do you compensate somebody for having a 3-hour delay in I was anxious for the 3 hours I was in the extra that I was in the hospital because I wasn't discharged on time. Even they admitted their mistake. You can claim you had emotional distress during the 3 hours you were anxious and the like. It just doesn't count for a lot.
It's just like crazy because like even Jenny's example, like I can only imagine like what could have been going through her brother's mind through that whole thing, like how emotional.
Oh, it's horrible. I mean, I think I'm
he
sure
must have felt.
I'm sure that people have claimed PTSD associated with traumatic events like that as well, where you might, if there's a real documented history of subsequent PTSD and you don't go to doctors anymore and you're terrified all the time. But yeah, it's really hard to prove. It's really, really hard to prove. So we did, we actually ran a little bit over because I know I'm supposed to end at 1:40. But we did a little bit of potpourri at the beginning and a more formalized lecture so that you guys can walk away with substantive information. We can talk about how to prevent malpractice in your own world as well as a lecture, if that holds interest to you, so you can take it away for your career. Any other final questions? Because otherwise I'll just wish you a wonderful weekend, and reach out to me at any time to work on getting it. The sooner you choose a topic, the happier both of us will be. It's just going to make your own life so much easier. So yeah, feel free to reach out at any point. Again, phone call, text, email, whatever you would, Zoom. It's all good. Well, great. If you anybody's are winter sports fans, we should be getting 48 inches in the next 24 hours. If not, stay inside and find a fireplace to stay warm. And be safe out there. And again, reach out if there's anything I can do.
So we're just continuing to look at topics for Tuesday.
Yeah, there's an entire assignment. Hang on, let me just tell you what. No, the assignment that we're going to discuss. Oh, hang on. There's a TED Talk. There's an 18-minute TED Talk that's going to be, and the questions. We're going to talk about the paper topic. We're going to talk about Kaiser Health News, but the second half of the class will be to discuss the TED Talk. It's 18 minutes long. That raises a bunch of issues about social determinants of health and a little medical malpractice. Now that we've just talked about that today, so those assignments are there. We shouldn't take that long. So it's all good.
Thank you.
Thank you.
Thank you.
Great job. Be safe, everybody.
Sorry, quick question. Could like
Oh, hang on. Let me turn off the recording so we don't.